Well, now let's see this one. You are able to see a cut section of a tumor, and this is basically a lobulated one. Okay, you are able to see firm, fleshy, somewhat creamy or pale tan colored specimen, right? So this is nothing but your dysgerminoma. Okay, so the size of the tumor is somewhere between 5 to 15 centimeter, and this is the second most common germ cell tumor till now. Okay, and you have to know that this tumor is bilateral in 15 to 20% of the neoplasms, and this germinoma means germ. So they have germ cells that have not differentiated to form any embryonic or extra embryonic structures, right? And this is a histopathological section of dysgerminoma. You are able to see tumor cells which are arranged in lobules, just like how we have seen the specimen. Then you have round to polygonal cells with hyperchromatic nuclei. Each cell is round to polygonal with hyperchromatic nuclei, and you are able to see fibrous septa that is lying between the lobules, and you have lymphocytic infiltration. Okay, you are able to see this blue colored cells. These are nothing but the lymphocytes that has infiltrated into the fibrovascular septa. Okay, so this is very important. And you have to know that dysgerminoma is the counterpart of seminoma, a tumor that happens in males, right? Okay, so how will you manage this patient? So management of this patient, usually she is a young female and for a female who is having her cancer in her early stages, say stage 1 cancer, then you can offer her unilateral salpingo-oophorectomy, that is a fertility preserving surgery, and in elderly women as well as in later stages, you will offer them total abdominal hysterectomy with bilateral salpingo-oophorectomy, and lymphadenectomy will be done whenever needed. Okay, and you have to know the fact that this tumor is very good response to treatment, and they have very good prognosis and also very good 5-year survival rate also, right? Now coming to this, so if you see this histopath picture, you are able to see a central blood vessel, right? A central blood vessel that is surrounded by cells. Okay, so these cells are lined by they are somewhat cuboidal in shape, right? They are somewhat cuboidal in shape with hyperchromatic nuclei. Okay, so you are able to get this picture, right? So this is something called as your Schiller dual body. Okay, sorry. So this is something called as your Schiller dual body. So this is seen in your endodermal sinus tumor. This is seen in your endodermal sinus tumor. Okay, so endodermal sinus tumor is a tumor that is derived from the primitive yolk sac, and it is a highly malignant tumor. These are almost and always unilateral tumors, and they are all large size also. Okay, about 10 to 30 centimeters. Okay, so this is one tumor where there is a need of chemotherapy right from the stage 1, because the prognostic outcome with these patients is very poor. Clear? Right. Now see this cut section. What are you able to see? You are able to see areas of hemorrhage, right? So there are areas of hemorrhage with here cystic changes, and here some mucoid like substance, right? So cystic and gelatinous substances. Okay, so this is how a cut section of a endodermal sinus tumor will be. Clear? And as I told, the tumor has a very bad prognosis and most of the patients will die within 12 to 18 months of diagnosis itself. Okay, right. Now let's see the next one. Yes, this picture. So what you are able to see? You are able to see something called as the Call-Exner body. Okay, so these are called as Call-Exner bodies. Okay, here you have cells but you don't see a blood vessel. Okay, here also the cells are arranged around a cavity. Okay, this is an empty cavity, you don't have a blood vessel here. Okay, so that is how you differentiate between a Schiller-Duell body and a Call-Exner body. Okay, so Call-Exner bodies are pathognomic of which tumor? Yes, it is going to be the granulosa cell tumor, right? So granulosa cell tumors includes both your Thicot cell tumor as well as your fibromas, and these are most frequent in the reproductive age group. If you see the gross picture of these tumors, some are solid tumors but most of them are going to be cystic tumors, and on cut section you will be able to see a cyst that is going to be filled with serous fluid or even hemorrhagic cyst, that is a cyst that is filled with blood. Okay, and histologically we have seen the Call-Exner bodies which are having a central cavity and surrounding that the cells are present, right? Okay, and these tumors are mostly going to be unilateral tumors, so we will offer them unilateral oophorectomy. Okay, and coming to this one, so this picture you are able to see some clear cells, right? That is cells which looks like a vacuole, inside you don't have any that is nucleus or something, right? So these are clear cells. So this is a picture of clear cell adenocarcinoma of ovary. Okay, you have cells with clear cytoplasm, right? Some other type of cells called as Hobnail cells seen in these type of cancer. So here you will have a characteristic bulbous nucleus and there will be nuclear projections into the cytoplasm. Okay, and a Hobnail cell is seen in clear cell ovarian adenocarcinoma and also your collecting duct carcinoma as well as end stage cirrhosis. Okay, so this is a clear cell that is seen in the ovary. Okay, I want to mention another clear cell carcinoma here, which is the clear cell carcinoma of vagina. Okay, so the risk factor for clear cell carcinoma of vagina is a girl's mother. Okay, a girl's mother, that is the patient's mother who took diethyl stilbestrol in her pregnancy. Okay, so that is very important. Okay, so what happens means there will be vaginal adenosis for the kid at birth and that will develop into vaginal clear cell adenocarcinoma during her adolescence. Clear? Right. Now, yeah, this one. So, you are able to see this picture where I have mentioned, the slide is mentioning there are Reinke crystals. Okay, Reinke crystals are nothing but these pink color areas. So, these are eosinophilic, that is somewhat red color crystalline inclusions. Okay, it can be intracytoplasmic or it can be intranuclear, anything. Okay, so this is seen in hilous cells of ovary. That means this is seen in hilous cell tumor of ovary. Clear? Next one is this picture. Okay, so you are able to see a nest of cells here. Okay, so what it is? Yes, it is going to be a vaulted cell nest. Okay, so these are nothing but a cluster of epithelial cells that is most commonly found in the connective tissue of the fallopian tubes or any other place, and here in gynecology will get vaulted cell nest in Brenner tumor. Okay, Brenner tumor of ovary. And next picture is showing tumor cells separately and tumor cells with signet ring separately. Okay, so if you take a tumor cell, this has a signet ring like this. Okay, so that is a sign where the tumor is going to be a Krukenberg tumor. Okay, so this is nothing but a signet cell is nothing but a large cell with a large vacuole. Okay, now let's discuss some of the tumor markers of your ovarian carcinomas. So, your ovarian tumor and the tumor marker. Okay, so for epithelial carcinomas, the tumor marker is going to be CA125, and for your mucinous tumors, the tumor marker is going to be CA99 or CEA, carcinoembryonic antigen. And for your dysgerminoma, the tumor markers are LDH and placental alkaline phosphatase. You have mature teratoma where the tumor marker is alpha fetoprotein. Next one is your granulosa cell tumor, for which inhibin is the tumor marker, and finally we'll have the endodermal sinus tumor, for which is again AFP is going to be the tumor marker. Okay. Now let me also tell the pathognomic findings what we have seen here. In the epithelial tumors, what we have seen, it is your sarcoma bodies. In dysgerminoma, we have seen there will be lymphocytic infiltration, right? In mature teratoma, you will be able to see all three germ layers, and along with it, we have seen the Rokitansky protuberance, right? And in granulosa cell tumor, it is your Kohl-Exner body. Endodermal sinus tumor, it is your Schiller-Duval body, right? So, other than this, we have seen signet ring cell in Krukenberg tumor, vaulted cellness in Brenner tumor, then Reinke's crystal, right, that is in Hylas cell tumor, as well as we also have hobnail cells, right, that is seen in clear cell tumor. Is that clear? Right. Now, see this picture where you are able to see numerous largely circumscribed white patch areas in the X-ray. So, these are nothing but your, yes, cannonball metastasis. So, these are all cannonball metastasis. You have large well circumscribed lesions. Okay. So, the two important causes for these kind of pulmonary metastasis are, number one, it is your renal cell carcinoma. Number two, it is your choriocarcinoma. Okay. Now, let's talk about the classification of gestational trophoblastic disease. We have molar pregnancies, that is hydatidiform mole, which can be a partial one or which can be a complete one, or it can be a invasive mole also, right? And you can have trophoblastic tumors. Trophoblastic tumors can be choriocarcinoma or placental site trophoblastic tumor, or even your epithelioid trophoblastic tumor. Okay. Yes. Now, how staging of GTN is done? Okay. When you understand staging of gestational trophoblastic neoplasia, you will come to know why that picture is shown, and we are talking about choriocarcinoma. So, stage 1 is where the disease is confined only to the uterus. In stage 2, the disease extends outside the uterus, but it is limited to the genital structures. And stage 3 is one where there can be metastasis to the lungs. This can be with or without your genital tract involvement. Okay, so that is why this staging is very important, right? And finally, stage 4, all other distant metastatic cysts. Clear? So, this is about the staging of gestational trophoblastic neoplasia. Now, let's see this one where we have WHO prognostic scoring system for gestational trophoblastic neoplasia. Based on this scoring system only, we are going to give them treatment. Okay, either chemotherapy or radiotherapy or surgery. This is planned based on this scoring system. Okay, so this is a WHO prognostic scoring system for gestational trophoblastic neoplasia. Now, what is the difference you have to see in this scoring system? Means the risk factor is given scores right from 0. 0 is there, 1 is there, 2 is there, 3 is missing. Clear? You don't have 3 here, you straightly have 4. And the risk factors are age, antecedent pregnancy, interval in months, pre-treatment serum HCG, that is given in international units per milliliter. Then you will be checking for the largest tumor size, then the site of metastasis, how many number of metastases you have, and if there is a history of prior failed chemotherapy. All these risk factors are considered. Okay, so the score will be given from 0, 1, 2, 3 is not there, 4, and these are all the risk factors, right? So age consideration we are seeing. Okay, so it is less than 40 years or more than 40 years. Done. Okay, not above that we are not speaking anything. So antecedent pregnancy can be a MAT. Okay, so it can be a molar pregnancy, or it can be abortion, or it can be a term pregnancy. Yes, we are done with it. Now interval in months. Okay, months you have to start from 4. Okay, we have to start from 4. So 4, 4 to 6, 7 to 12 and more than 12. Right? And pre-treatment beta HCG and largest tumor you have to keep in mind number 3. Okay, so it is 10 to the power 3, 3 to 4, 4 to 5 and more than 5. Right? Then size of the tumor, it is less than 3, 3 to 4, more than 5, and here you don't have anything, you have to remember that. Okay, size of the tumor, only 3 values we are entering, less than 3, 3 to 4 and more than 5. Site of metastasis, it is lung for 0, spleen, kidney for 1, for 2 gastrointestinal tract, and if it goes to brain and liver, will give straight away score 4. The number of metastasis, okay, for 0 you don't have, and number of metastasis 1 to 4, 5 to 8 and more than 8. Okay, and prior failed chemotherapy you don't have anything here, and single drug failed you will give score 2, and more than 2 drugs are failed then you will give score 4. Okay, yes. Now the cutoff is less than or equal to 6. That means the patient is a low risk patient. Okay, when the patient is low risk patient, you will offer them single agent as an IM injection. So what is the agent we use here? Yes, it is going to be a methotrexate. Okay, so the dose of methotrexate we give is 50 milligram. Okay, methotrexate is given as a 50 milligram IM dose, and it is given with folinic acid rescue. Okay, so folinic acid tablet is given 15 milligram orally. Okay, so these drugs should alter. For example, if you are giving methotrexate on day 1, day 3, day 5 and day 7, folinic acid will be given on day 2, day 4, day 6 and day 8. Clear? So this is how it will be going, and the same dose will be repeated every 2 weekly. Right? Yes. Now after HCG has resolved to normal, you will give 2 to 3 more cycles of chemotherapy. Even if it becomes normal, you will give 2 to 3 more cycles of chemotherapy. Alternatively, instead of giving methotrexate and adding folinic acid rescue, if you want to give a single alternative drug, means you can go for actinomycin D. Okay. Suppose if there is failure in this single agent regime, or the score is more than or equal to 7, then they are said to be at high risk, and these people are treated with multi-agent regime. Okay, multi-agent chemo regimen. So that regimen is also called as Baksha regime. Okay, where we will be using 5 drugs, that is your Imaco. Okay, so that is your etoposide, methotrexate, actinomycin D, cyclophosphamide, as well as your vincristine or oncovin. Clear? Right. And if it is not supported with these chemotherapy, you can even try to switch on them to the radiotherapy or hysterectomy you can do. Okay? Yes. Now see this lesion. What you are able to see? You are able to see somewhat ulcerated and reddish raised lesion that is seen on either side of the labia, right? So what do you think this is going to be a? Yes, this is a case of vulval carcinoma, right? So usually the lesions can be raised, pigmented or ulcerated with everted margins. Okay. The lesions are commonly single and of course multiple lesions are also seen. 98% of these cancers occur in elderly women rather than younger. Okay. And in the elderly, this is usually a single lesion and multiple lesions are seen in comparatively younger women. Clear? So, when you see such a lesion, you have to assess the involvement of urethra, vagina, surrounding structures also you have to examine, right? Yeah. Now, what do you think this is? Yes, here you are able to see warty lesions, right? So, these are having cauliflower-like appearance. So, these are nothing but what here? Very good. Condyloma acuminata, right? Condyloma acuminata, which is caused by human papilloma virus 6 and 11, right? So, the most common site of these lesions are the cervix, but they can also be seen on the vulva, vagina and anus. Okay, so in simple words, these are nothing but your genital warts. Clear? Right. Now, how will you treat these patients? So, treatment can be given by giving them podophyllin or trichloroacetic acid, okay, but these are contraindicated in pregnancy. So, what you will do in pregnancy? You will offer them laser or cryotherapy or even diathermy, or directly you will go for surgical excision. Okay. You can also give them HPV 6 and 11 preventive vaccine, that is HPV vaccine can be given. Clear? Right. Now, before going on to the discussion of HPV vaccine, let me tell this HPV, when it is invading the epithelium, it will be producing certain changes and the cell will be transformed into a special type of cell called as coilocytic cell. Okay, so these cells, if you see, they are larger in size, they have a bigger and hyperchromatic nucleus with a perinuclear halo. Okay, so these are coilocytic cells. These are blue in color because they are checked by colposcopy after staining with toluidine blue dye. Okay, so these are pathognomic cells or characteristic cell types that are produced by your human papilloma virus. Now, let's talk about HPV vaccine. Okay, so HPV vaccine, there are mainly 3 types of vaccine that is active against almost all the types of human papilloma virus. Okay, so we have Cervarix vaccine that is active against HPV serotypes 16 and 18 that gives protection from cancer cervix. Also, we have Gardasil that is active against the lower HPV serotypes also like 6, 11, 16 and 18. So with this vaccine we'll have protection from genital warts as well as CA cervix. And the third type of vaccine is Gardasil 9. So this is going to be active against HPV type 6, 11, 16, 18, 31, 33, 45, 52 and 58. This is also going to protect against genital warts as well as CA cervix, right? So you have to know these vaccines are produced from L1 capsid protein. Okay, so because of this protein, they will be forming virus-like colonies but lack the DNA for infection. So it is non-infectious, right? Okay, but they are highly immunogenic. They will be highly immunogenic. So they will produce specific type of humoral antibodies to protect against the entry of human papillomavirus into the epithelial cells, right? Yes. Now you have to know HPV virus is contraindicated in pregnancy and it is safe during lactation. Obviously, we will not be giving it to a person with any allergy or recent febrile illness like that. Okay. So, what is the age group for vaccination? That is another question, right? So, age group of HPV vaccination ideally is going to be between 9 to 26 years, but we can even give them from 27 to 45 years also according to your FDA recommendation. Okay, right. So there is a recent WHO SAGE recommendation for HPV vaccination that came out in April 2022. Okay, so this recommendation says if the patient is between 9 to 14 years, you will give them 1 to 2 doses of HPV vaccine. If the patient is between 15 to 20 years, then you will give 1 to 2 doses again. If the patient is above 21 years, you have to give them 2 doses and this should have a 6-month interval. And suppose if the patient is HIV positive, you will give them 3 doses, right? So there is also some targets that are planned to be achieved by WHO, that is WHO Global Strategy to be achieved by 2030. This says that 90% of eligible girls should be vaccinated against HPV and 70% of eligible women should be screened at least twice during their lifetime. And the third point is to effectively treat 90% of those who are with positive screening test or if they have a cervical lesion, okay, including palliative care. Okay, so these are the targets to be achieved by 2030. So this can also be kept in mind like 90, 70, 90 strategy. So 90% people should be vaccinated, then 70% of them should be screened at least twice in their lifetime, and 90% of them with a positive screening test or a cervical lesion should get at least palliative care. Clear? Right. Now let's see the permanent methods of sterilization in female. Okay. So this picture shows the fallopian tube being taken into loop by Babcock's forceps. Then at the base of the loop, they are tying a single tie, and then they are cutting the tubes in the loop, and finally they have left the suturing as it is, and finally they have reabsorbed, and this stature is obtained. So what do you think this type of sterilization is? Yes, this is going to be Pomeroy technique. Okay, Pomeroy technique of female sterilization. And the next one, here you are able to see the tube is ligated twice on either ends, right? And then they have cut the tube, and one end of the tube, that is the medial end, was mobilized by dissecting. Okay, they have mobilized it by dissecting from the mesosalpinx, and finally they have buried it into the uterus itself, right? And the lateral end is buried into the mesosalpinx. Okay, so what do you think this procedure is? Yes, this is Irving's method of sterilization. Yes, and coming to the next one. Here you are able to see the mesosalpinx is infiltrated with saline or epinephrine, and finally an incision is made. Okay, and they are separating the muscle layer of the fallopian tube, and then the tube is cut. Here the medial end is buried into the mesosalpinx, and the lateral end is kept outside the mesosalpinx. See, the lateral end is kept outside the mesosalpinx. So this procedure is your Uchida technique. Okay, this is your Uchida technique of sterilization. And yeah, this method, you are able to see they are targeting an avascular area, right? Avascular area in the mesosalpinx, and finally a perforating. Okay, they are perforating with the scissors, they are trying to perforate the mesosalpinx in that avascular area and entering, and the tube is already clamped by the Babcock's forceps, and finally they are double ligating the tubes on either side of the Babcock's, and then that particular area of the tube is cut and excised out. Okay, so this method is nothing but your, yes, very good, this is your Parkland technique of female sterilization, right? Okay, now in this method, if you see, they are done, repeating once again. So in this method, if you see, they have done nothing but just they have taken the fimbria out. Okay, so this is your Kroner's fimbriectomy. This is your Kroner's fimbriectomy technique. Clear? So these are the permanent methods of female sterilization technique. Clear? Right. Now, let us also talk about the male sterilization technique, that is non-scalpel vasectomy or NSV. Clear? See, basically here we are going to do vasectomy. Vasectomy means bilateral vas deferens or ligated. Okay, so there are two methods, either a conventional method of doing it or a non-scalpel vasectomy. Non-scalpel vasectomy means there is only one single puncture technique. There is no stitch needed, whereas in a conventional technique you need multiple stitches. There is no need for anesthesia. It takes only less time, as well as it has less post-op pain, as well as it has less complications also. Okay, and after doing this procedure, in the post-op, you have to advise the man to wear tight underwear or bandage for 24 hours, Then for 24 to 48 hours, he should rest in supine position, and it is necessary that 20 ejaculations should be done after that to clear the sperms. So, first 3 months you have to advise them to take additional contraceptive measures, and after 4 months you will offer them a semen analysis, and in the semen analysis, if you are able to see two of the samples are semen free, then you will declare the procedure as a successful one. Clear? Right. Now, this is how a non-scalpel vasectomy is done. Basically, a local anesthesia is infiltrated, then the vas will be taken out, and we'll be using two special instruments for this. One is a ringed clamp and another one is a dissecting forceps. Okay. So, with the help of ringed clamp, the vas is brought out, and finally with the dissecting forceps it is being dissected and the vas is cut, and finally a single band-aid is put over the single suture made. Clear? Right. Now, this is a ringed clamp. Okay, you will have a closed ring about 3 to 4 millimeter. Okay, so that will be helping in taking the vas out without injuring it, right? And this is a dissecting forceps. Okay, this is a dissecting forceps that is used in non-scalpel vasectomy. Clear? Right. Let's see some of the instruments that are used in gynecology. So, this is a female metal catheter. Okay, female metal catheter. See, usually female metal catheter is used to evacuate the bladder routinely before surgery. If there is any retention of urine due to any cause, then you can use this bladder to evacuate the urine, and it is also used in diagnosis of vesicovaginal fistula, as well as we can find the limit of the bladder during or anterior colposcopy operation. Clear? Right. Now, what are these? These instruments are nothing but your Heger's dilators. Okay. So, usually an uterine sound will be used as a first dilator. After that, you can increase the size and can use until the cavity is open, okay, to perform the procedure, right? So, it will be very painful if the os is not dilated. Okay, so that's why you have to give pre-op misoprostol about 200 milligram, that can be given either via the oral route or the vaginal route 4 hours before the surgery, right? And this one. So, this small instrument, okay, this is actually scissors, right? So, this is a mosquito scissors. Okay, so these are multi-purpose instrument. This will handle the blood vessels and prevent blood loss. Okay, yes. Next one, yes. This instrument is a cervical punch biopsy forceps. Okay, so this is a biopsy punch forceps. It is commonly used during colposcopy to obtain cervical tissue biopsy. Clear? Yes. And the next one, yes. So this instrument is a Babcock forceps. Okay, you have to see the tip. How is the tip? Okay, so this is a Babcock forceps. Okay, so you will be having a fenestration in the center. That means it is a Babcock forceps. So this is a Babcock's tissue forceps. So this is basically used to grasp the structures where gentleness is needed. Repeating once again. So this is basically used to grasp the structures. Repeating once again. So this is basically used to grasp the structures where gentleness is needed. Okay, so that's why it doesn't have any tooth also, right? So parametrial we can use it in tubal ligation, even to hold the ureter in case of doing any bigger hysterectomy like a radical hysterectomy, or to hold the lymph nodes while you are performing lymphadenectomy, or even to hold the appendix during appendicectomy and also during internal iliac artery ligation, right? Yes. And yes, this instrument. What is this instrument? This is a myoma screw, right? So this is a myoma screw. Basically, this one is used to hold the myoma like this. Okay. So with this, we can hold the myoma during myomectomy. Okay, that means it will be helping it in enucleating the myoma from the surrounding myometrium, right? As well as we can also use it in hysterectomy to hold and fix the uterus, right? Next one. So what is this instrument? This instrument is a Boney's myomectomy clamp, right? So this is a Boney's myomectomy clamp. So this instrument is basically used in your myomectomy by compressing the uterine arteries temporarily. Okay, so it will compress the uterine arteries temporarily, right? Yes. Next one. What is this retractor called as? This retractor, a L-shaped retractor, it is called as, the name also starts with L, okay? It is a Landet's bladder retractor. Okay, so this is basically used to retract the bladder during your vaginal hysterectomy. Okay, as well as it can also be helpful in your vesicovaginal fistula repair to retract the lateral vaginal wall. Clear? Right. Now, next one. So, what are these? These are nothing but ring pessaries, right? So, these are the ring pessaries. It is made up of either rubber or polyurethane, and it is used for the treatment of pelvic organ prolapse, right? So, these ring pessaries are given to people who decline surgery or who are unfit for surgery, or to women who have prolapse during pregnancy, or whose desire of childbearing. Clear? Yes. Now, a similar type of pessary, but the difference between a prolapsed pessary, that is a ring pessary, which is exactly a ring in shape, and this is somewhat asymmetrical. So, this pessary is nothing but your Hodge Smith pessary. Okay. So, this is used in your retroversion of uterus. Okay. Yes. Now, coming to this one. So, what are these? You have a conical shaped apex, right? I have shown you this already in this session. Yes, this is a Leach-Wilkinson cannula or a hysterosalpingography cannula. Okay, so this is basically a metallic cannula that is used to do a tubal patency test, that is nothing but your hysterosalpingogram. So, a tubal patency test or a HST test is usually done between day 7 to day 10 of a cycle, and the dye which we commonly use in HSG is urographin dye. Okay, this is a water based dye, so you have only less complications. Okay, so the complications you can expect in a HSG include embolism or pelvic infection, or there can be extravasation of the dye as well. Clear? Yes. Now, this instrument is very important. Okay, you see the tip, there is an opening, and with the tip we can apply ring over that is your tubes in laparoscopy. So, this is a Fellope ring applicator. Fellope ring applicator. Okay, so in this we will do tubal occlusion methods. A tube can be occluded by 3 devices. One is a Fellope ring, what is shown in the picture. Then it can also be a Filshie clip that is made up of titanium, and finally we will have the Halka Clemens clip. Clear? Right. Now, we are able to see a wooden spatula. Yes, this is nothing but your Oyer's spatula. Okay, here you are able to see a pap brush, or this is also called as cyto brush. Right. Now, this wooden spatula and cyto brush are used to take pap smear. Okay, pap smear or a smear for cytology. Okay, that can be a cervical cytology or a vaginal cytology. Okay, now let's discuss what are the indications of doing a cervical cytology. So, cervical cytology is usually done when there is any status of genital cancer. Okay, and it can also be used to take and study the hormonal status of vagina. Okay, hormonal status of vagina, and which wall of vagina you prefer to take the smear? It is usually your lateral wall. Okay, yes, and we can also determine sex chromatin. Okay, like it is usually done from a buccal smear. Okay, to take a buccal smear also this spatula is used. Right. Previously wooden spatula was used, but nowadays we are not using wooden spatula because since we are collecting only the superficial cells, they can enter into the micropore of wood. Okay, so nowadays our spatula is made up of plastic. Right. Now, oil spatula is used to take smear from the squamocolumnar junction, whereas the cytobrush is used to take a specimen from the endocervical canal. Okay. So, before that you should know the squamocolumnar junction. In the cervix, you have something called as ectocervix that is present outside, and you have the endocervix, and between the ectocervix and endocervix, you have something called as the endocervical canal. Remember, the ectocervix is lined by squamous cells, and then the endocervix is lined by columnar cells. Okay. So, the junction between these two layers is called as squamocolumnar junction. And remember, this squamocolumnar junction is not a static zone, it is a dynamic zone that is going to change during the entire life of a female. The region that is present between the old squamocolumnar junction and the new squamocolumnar junction is known to be transformation zone. Okay, and transformation zone is said to be the common region for occurrence of carcinoma cervix. Clear? Right. Now, well, this instrument is something which is made in plastic, and you have a single tube-like instrument. Okay, so this is basically your pupil forceps that is used for taking endometrial biopsy. And this is your Vobra aspirator that is used for taking endometrial biopsy. Okay, usually pupil forceps is used to take endometrial biopsy in people who are complaining of endometrial bleeding. Repeating once again, usually pupils biopsy is taken for people who are having postmenstrual bleeding or severe intermenstrual bleeding, or you see an occasional endometrial thickening which is more than the cutoff of their respective age group. Okay, yes. And this is usually done as an office procedure. There is no need for any anesthesia and all, right? Now, what is this? So, this is a colposcopy procedure. Okay. So, in colposcopy procedure, we'll be visualizing the cervix, vagina, everything using a colposcope, and we'll be taking the necessary biopsy from any doubtful lesions only. Okay. So, this is a colposcope. So, basically we will be going for visualization of the cervix, vagina and vulva under magnification. Okay, that is important. Under magnification, we will be taking biopsies from pre-malignant as well as malignant lesions. Okay, you will place the patient in dorsolaterotomy position, and after inserting the speculum and focusing the colposcope, you will check for the lesions with low power initially, that will be moved to a higher power, okay, for better visualization of the lesions. Okay, then the lesions will be stained with 3% acetic acid as well as glucose iodine. Okay, just like how we do for our Via and villi test. Okay, then a biopsy will be taken. Okay, there will be so many abnormal patterns that can be seen with colposcopy. Grade 1 of abnormal findings will include fine mosaic pattern of vessels or fine punctuation of vessels. Okay, and grade 2 abnormal lesions in colposcopy will include coarse mosaic pattern or coarse punctuation that will be having a sharp border like that. Okay, and you have to know a score called sweet score, which is used in colposcopy. Here we use 5 components. Okay, we use 5 components to arrive this score. Okay, so the components will include, so how about the aceto uptake, then how are the margins or the surface of the lesion, then you have to check the vessels, also the lesion size, and how is the iodine staining. So these are the 5 components. So aceto uptake and iodine staining. Vessels we have seen. What is the lesion size and how is the margin or surface of the lesions you have to check. Okay. So this is called a sweet score. If the score is 0 to 4, it can be interpreted as a low grade lesion or CIN1. If the score is 5 to 6, then it can be interpreted as a high grade lesion or CIN2. And if it is more than 7 till 10, it will be interpreted as a very high grade lesion or a suspected case of invasive cancer. Okay, so that is a suspected case of invasive cancer. Clear? Right. Now coming to this one. Okay, so that is application of acetic acid over the cervix, okay, to find out any abnormal lesions are present or not. So what we are basically doing is, we are applying acetic acid here and will be checking for any acetowhite areas. Okay, so if the acetowhite areas are present, then they are considered to be abnormal, right? So this is a similar test, that is Villi test, where we'll be applying Lugol's iodine. Okay, Lugol's iodine. Since the cervical epithelium is rich in glycogen, okay, the normal cervical epithelium will be staining mahogany brown. Okay, so that is normal. Whereas that with neoplastic epithelium will be stained somewhat like mustard yellow in color. Okay, so this is mustard yellow in color, which are abnormal. The mahogany brown color are said to be normal. Clear? Right. So this test is also known as Schiller's test. Okay, so these are used in developing countries for screening purposes.